I am Dr. Kalaiselvan, working as Principal Scientific Officer at Indian Pharmacopoeia Commission, which is a national coordinating center for Pharmacovigilance Programme of India. Basically, I am a pharmacist by profession. The Pharmacovigilance Programme of India, we used to call it as PvPI, came to Indian Pharmacopoeia Commission. The assignment was given to IPC, Indian Pharmacopoeia Commission, in the year 2011. So previously, before 2011, the program, in India, the pharmacovigilance activities, carried out in a scattered manner, either project mode, the pharmacovigilance as a project mode, or academic point of view. Some of the interested organizations, they used to do a pharmacovigilance, otherwise no. But once it came to Indian Pharmacopoeia Commission, we started building a network among the stakeholders. We brought all the institutions, all the interesting organizations under one umbrella, and we could able to build a strong network or effective communication with the stakeholders. So that was the first step we took to promote patient safety, pharmacovigilance in India. So according to us, according to me, the pharmacovigilance, effective communication and management is very important for pharmacovigilance, which we could able to learn from the previous program, why the previous programs could not able to succeed in India. There was lack of communication, or the proper organization was not there to coordinate the activities. So once Indian Pharmacopoeia Commission assumed this office as a national coordinating center, we started working with different partners, different stakeholders, particularly Uppsala Monitoring Center and WHO. Then gradually we started identifying more number of ADR monitoring center, regional centers, and then we could able to establish quality as well as quantity of reporting. And the most success of this program, I would say, we could able to connect with our government properly. We could able to convince our government. We could able to convince our system and policy makers to understand about the importance of pharmacovigilance. So that was the success. Country like India, there are challenges, particularly under-reporting. The reason is under-reporting, workload of the doctors, because their doctors are overloaded. They will not, this is spontaneous, since it's a spontaneous, they will not get time to report. So it's a kind of solicited spontaneous reporting. We should approach them and we should ask them for adverse drug reaction. So it's the biggest challenge. Of course, there is a need of a lot of education and awareness among the clinicians to report ADR. And India, another challenge, the pharmacists are to be empowered. Pharmacist empowerment is very much required to enhance the ADR reporting. That is the biggest challenge, I would say. Maximum report from hospitals, like setup. We have setup of ADR monitoring center. We have system over there. We identified one focal person. Then we have our staff, PvPI staff is working in every hospital, every ADR monitoring center. Through them, the reports are coming. Yeah, reporting from doctor, reporting from nurses. See, the National Coordinating Center, which comes under the Ministry of Health and Family Welfare, Government of India at Ghaziabad, which is close to Delhi NCR region. That is the headquarter for pharmacovigilance. And under this umbrella, under this NCC, we have ADR monitoring center, regional ADR monitoring center. Every state and every union territory, every state in India, we have established ADR monitoring center. Then, in order to provide regular training to the ADR monitoring centers, we have identified 11 regional training centers, including JSS, one of our regional training center. So every year JSS, at least one training program JSS will organize for the pharmacovigilance team nearby area, nearest to this place. So similarly, KEM, King Edward Memorial Hospital, and Seth GS Medical College, Mumbai, is one of our training center. We have one training center in East. Geographically, topographically, we identified training centers. So it's mean that the person from Mysore not necessary to come to Delhi for training. He can attend the training at JSS. So India is such a big country. Every time we cannot invite the people to come to Delhi. So it makes lot of investment, lot of expenditure would be more. So in order to reduce the expenditure as well as to train more people, we have identified zonal training centers. This is a very important question. I know our future plan, our program is we need to expand the program outreach to district level hospital. So in India we have more than 600 districts. Now our respected our DCG, Drugs Controller General of India, as well as Ministry is very keen to expand or to disseminate this program up to the district level. So now our plan is we need to identify more number of district hospital as an ADR monitoring center. Currently the ADR monitoring centers are up to the level of metro cities or below that. So now our next plan would be we need to go up to the district level. That is the plan, next plan. And we ultimately want to bring this Pharmacovigilance Program of India emerging to advanced. Now it's emerging, now we want to bring it to advanced. I am very optimistic, I am very confident because everybody support, UMC is supporting very well, UMC support is there, WHO support is there, and everybody is on board. We have very good communication, very effective system. Again, I want to stress that communication and very good partnering, working relationship with everybody is very good. So I am 100% confident and very optimistic that we are going to be emerging to advanced.